The broadcast is now starting. All attendees are in listen-only mode.
Good evening, my name is Kim Green, and I'd like to thank you for joining our webinar. All of you will be in listen-only mode during the presentation. This webinar is 60 minutes long. At the end of each case study, Dr. Kraus will open it up for questions, at which time please raise your hand and I will unmute you. And here is Dr. Kraus.
Thank you, and thanks everybody for coming on board with this webinar. Some of you, I'm assuming, may have been at the previous webinar. So this is the next disease topic, so to speak, urodynamic interpretation of stress urinary incontinence. I want to keep these as interactive as possible, but as Kim mentioned, we ran into some technical issues. It's just the downside of doing this as a webinar as opposed to being in person. In terms of keeping everybody verbally active so that they can hear us and not mute you. The problem is that there's a lot of background noise, so we can't do that again. What we'll try and do, if time allows, is we'll try and basically do one case at a time, and then, again, as Kim mentioned, raise your hand, somehow let us know, we'll unmute you and see how it goes, if time permits. That's the big thing. That will take a lot of time. So, moving on, urodynamic interpretation of stress incontinence. That's me that you see on the slide. Just as a just let everyone know, I'm a urologist, for those who weren't on the previous one. And you don't need to have been on the previous one to do this one, so I don't want anyone thinking they missed. It's not like a sequel to a movie. If you missed part one, you'd still do fine with part two. I'm a urologist. I specialize in female urology, neurourology, and voiding dysfunction. I did my residency at Rutgers, and I did my fellowship at Baylor. I'm at the UT Health Science Center in San Antonio now for about 15 years. If you don't detect the twang, it's because I was actually born and raised on the East Coast, and I was actually in private practice. So I like to bring that in because that's important in terms of practice when we're supposed to do these talks. But I can say y'all with the rest of them, so I've been here long enough. So moving along, we're going to talk about, if I can get my thing to move. The goals of today's talk, we're going to define stress incontinence. Sounds pretty simple, but we'll define it. We'll review the stress incontinence guidelines that were put together by the American Urologic Association and the Society for Urodynamics, Female Pelvic Medicine Reconstructive Surgery, SUFU. We'll review the AUA SUFU guidelines for urodynamics and stress incontinence. Then we'll review some basics on urodynamics itself of stress incontinence, and then we get into the cases. So, moving along, the definition of stress incontinence sounds pretty straightforward. The symptom of urinary leakage during events that result in increased abdominal pressure, such as sneezing, coughing, physical exercise or activity, lifting, bending, or even changing positions. Pretty straightforward. Now, everyone thinks that, and the most common cause for that is it implies that there's a weak or incompetent outlet, urethra, pelvic floor relaxation, lots of various versions of it. There is also something called stress-induced overactivity, where you'll get an involuntary detrusor contraction caused by an increase in abdominal pressure. That technically is an unstable detrusor contraction, but what is the symptom? It's the patient saying, every time I cough, I leak. But it's not an outlet problem, it's the bladder having an unstable contraction. So we'll go into that in a little bit. It's not that common, but it is something that will show up once in a while. And again, these are straight from the AUA guidelines. They came out the original versions of the guidelines came out in the late 90s, and then they were updated in 2010, and the AUA is actually in the process of updating them again. Actually, full disclosure, I'm on the SUI guidelines panel, and I am not speaking on behalf of the AUA guidelines panel. So the guidelines panel, and again, we're referring to the 2010 guidelines, goes into what we call the index patient, which is an otherwise healthy woman with stress incontinence, and then or with and without prolapse. So that's the index patient, and we'll go over where urodynamics, if that at all, plays into that, and then the non-index patient. So the evaluation for the index patient is essentially the slide that you see. It is a focused history, a focused physical exam, assessment of a post-void residual, and a urinalysis. And that's it. It doesn't say anything about urodynamics. It doesn't say anything about pad testing and stress tests and such, other than on that focused exam, you really should see the stress incontinence. So The history should include a characterization of the incontinence. Is it stress? Is it urge? Is it both? If it's pure stress, then now we're still talking index patient. Do they have any symptoms of frequency? How frequent is the incontinence? This is not a frequency question. How frequently do they have stress incontinence? How much bother is it? How severe are the episodes? Are we talking about a couple drops when they cough, or are they pretty much requiring severe pads or diapers every time they cough or strain and such? Impact on lifestyle, and what are the patient's expectations of treatment? Expectations are a very important aspect of treatment, especially for this kind of problem, because it is a quality of life problem. It is not a life-threatening issue that has to be treated. If the patient doesn't like your treatment options, they don't need to do it. If they have expectations that are out of reality, that also is important. The patient who leaks a pad a day and wants to get better, that patient probably you're going to make her better. You can't guarantee dry, but the patient who leaks a drop or two, that patient may have such high expectations for treatment, you may not be able to achieve them. So you want to pick that up ahead of time. And then the focused physical exam, the main objective there is to demonstrate stress incontinence. And that is it. If you are able to do those things, and you've met the index patient, straightforward stress incontinence, no other problems, they don't complain of voiding issues, they don't complain of recurrent UTIs, they don't have urge incontinence or overactive bladder symptoms, they haven't had previous surgery, you see the stress incontinence on exam, you're done. You don't need to get urodynamics, you don't need to go past go, you can move straight forward to the next line treatment, which would be behavioral therapy, pelvic exercises, or surgery. Everyone used to believe you had to have urodynamics or some sort of test to prove they had it before they go to surgery, and that is not the case. Now, the guidelines do add that you can do additional testing if necessary, and this is the main thing, if it's needed. And the testing should assess the lower urinary tract function and integrity. And in that case, it's pad testing with or without avoiding diarrhea, urodynamics, cystoscopy if indicated, and imaging. And again, they're all if needed, and we'll go into what that means if needed. In fact, we're going to go into that now. Why would it be if needed? Well, let's say you have that index patient by all other criteria. She's a perfect index patient, but you do your exam and she just doesn't leak. We've all seen it. We've seen it on urodynamics too. It just didn't leak for you on exam. She may still be the index patient, or she may have something else, or she may have a different kind of incontinence, and you haven't figured it out yet. If they have concomitant overactive bladder, OAB symptoms, if they've had previous lower urinary tract surgery, especially, or not especially, but including a failed previous incontinence surgery, if they have any neurogenic bladder component, that negative stress test, we just talked about that. If they have an abnormal urinalysis, such as hematuria or pyuria, if they have an excessive residual urine volume, if it's much higher than you would expect, you're worried about voiding issues, dysfunctional voiding, which is one of the other bullets a little bit lower. If there's any question of voiding at all, if the patient says, I must strain, I have to change position every time I try and pee, I really push a lot, it doesn't come out easy, those are all, they should raise red flags. And then the last is significant prolapse, considered grade 3 or better, and they have incontinence and you are concerned about the possibility that the prolapse impacting on the inability to see incontinence, which is what we call occult stress incontinence, or if the prolapse is affecting how they urinate, which again we'll go into in a couple cases later. So, inability to make that definitive diagnosis on the initial exam, well, you know she has incontinence by history, she's a straightforward patient, otherwise she was a perfect index patient, but you didn't see leakage on exam. Well, one possibility is the bladder wasn't full. The other possibility is in that setting wasn't a time for her to leak. Stress incontinence is a dynamic process. You don't always see it, and the same criteria don't always cause leakage. Someone who may leak with lifting heavy weights today and then may lift heavy weights tomorrow and may not leak. It may have something to do with the bladder and the volume in their bladder. It may have something to do with their cognition of the leakage in their pelvic floor. They're tightening up their pelvic floor. They're doing Kegels, maybe even involuntarily, not realizing it. That's probably the most common reason why when you look for incontinence on exam, they don't leak. They know you're down there, or they're afraid that they're going to leak on you, and they hold it back. So those are possibilities, and you can easily figure that out with a urodynamic study. You redo the bladder stress test, basically, by filling their bladder up Now with a known volume of urine, you can measure how strong and how much effort they're putting into their Valsalva effort. And if they're not leaking, you can actually get an idea if their pelvic floor is tightening up by looking at an EMG, which we'll maybe, I think we have that. The non-index patient is the ones that we're really going to talk about, and those are the ones that are more complicated. They're the ones that have the concomitant OAB patients, OAB symptoms, urgent incontinence, mixed incontinence, the previous surgery like we talked about, especially the previous stress incontinence surgery, the high volume PVR, dysfunctional voiding, and high-grade prolapse. So moving along, the tests that you would need to do, cystoscopy is going to be not something we need to talk about that much. It's one slide. Basically, the obvious indication the patient has hematuria, they have recurrent UTIs, maybe they had a previous mesh sling, and now you're worried about erosion, possibility of a fistula from previous surgery, and also the worry about obstruction. Those would be the main reasons for doing cystoscopy. Now, it's not evidence-based. No one's actually ever looked at it from an evidence perspective to say cystoscopy helped you or didn't help you. Kind of like common sense. And if you no one actually, maybe I'm speaking up my I don't think anyone ever proved that a stethoscope evidence-based is indicated. Maybe they have, but cystoscopy to me is like that, and actually so is urodynamics. It should help you make the diagnosis, and that's going to be the recurring theme. This is not an evidence-based entity, so I don't think you'll be able to find it on literature, but that's what we know. We know cystoscopy is done for hematuria evaluations. We know that we're using cystoscopy to look for something that may or may not be there, and you're going to rule it out. So, urodynamics and complicated stress incontinence, what are you looking for? Evaluate the outlet. Maybe under more controlled circumstances, now you know how much is in the bladder. You filled it up with a higher volume. Maybe they'll leak now with a higher volume. You'll look for incompetency of the outlet, and if it is incompetent, how are you going to measure that? You want to look for that, what we call the low-pressure urethra or intrinsic sphincter deficiency, and we can do that with the Valsalva leak point pressure or the urethral pressure profile, which we'll get to in a little bit. Are you sure it's stress incontinence? They don't leak on exam. They didn't leak on your urodynamics. Maybe it's urgent incontinence, and they're giving you symptoms that are different than what are really being experienced. They always say, I got to go to the bathroom, and they leak, and you assume that that's urgent incontinence. That's what I would assume. Well, in reality, she's got bad stress incontinence, and what she's doing is she's trying to go to the bathroom very often in order to avoid having accidents. How does that translate to you? It sounds like she said, I go to the bathroom a lot, and I leak. Well, that sounds like OAB, but again, she's avoiding accidents by going very often. Then there's the patient who says, I leak all the time. 24/7, continuous dribble, they never stop leaking. That's who you have to worry about a fistula. I can tell you, I have patients who I know don't have fistulas, but I ask them how bad they leak. All the time, doc. All the time. I leak all the time. Never go a minute without leaking. Really? They probably don't have a fistula, but when they say those things, continuous leakage, it really does, you have to at least entertain it, especially if they've had previous surgery. They're rare. It's in the Western world, fistulas are relatively rare, but they do need to consider them. In this day and age with mesh, there is a slow, steady incidence of mesh erosions, and I've seen a couple of mesh erosions causing fistulas. So the mesh erodes into the bladder and also erodes into the vagina, and that creates a horrible situation. So something to be conscious of, but it's not a very common thing. Probably you do a better job of convincing the patient or asking the patient in such a way, do you leak when you're sleeping? Well, I wear a pad, I leak, but if you put the pad on now, will you be wet in 5 or 10 minutes from now? There may be ways to answer that question a little bit more accurately. With prolapse, that's a problem because patients will present with a vaginal bulge or prolapse, and they may not say they have any incontinence because the incontinence is being masked by a kinked or kinked urethra, which is obstructing it. And in obstructing it, it may hinder their ability to empty, but from an incontinence perspective, it may kink the urethra so they don't leak. The reason it's important is because if you correct the prolapse and you don't do anything about the urethra, well then, now they have a unkinked urethra, which is going to start leaking, and the patient will come back from their prolapse surgery and say, well, this is great, my prolapse is gone, but now I leak with coughing and sneezing, and I didn't do that before. So you can use urodynamics to help identify patients with that problem, and if you can identify them, you can either warn them that maybe they should have a concomitant sling at the time of the prolapse, or you can at least warn them that it's a possibility it's going to happen, and you may want to figure out what to do afterwards, but at least they know. Some people would say just do the sling. Others would say, let me wait and see. Maybe she'll have some stress incontinence, but it won't be bothersome to her that she needs to treat it. So you can have that discussion, but you can't have that discussion if you haven't determined they have a cold stress incontinence. Urodynamics will help you with that. And then look at the outlet for obstruction. Maybe they have overflow incontinence. Maybe they have overactivity secondary to an outlet obstruction. Obstructed voiding causes detrusor changes. The bladder has to squeeze harder, contract harder against a closed outlet. It's going to have changes morphologically in the bladder wall. The bladder wall will hypertrophy. You'll get detrusor hypertrophy, thickening of it, and that can cause OAB type symptoms as well. We see it very often in men. The most common situation is the guy with BPH who enlarged prostate who also has OAB symptoms. Well, lo and behold, they undergo a surgery for their prostate. They didn't have surgery for their bladder. They didn't have an OAB. And lo and behold, their OAB symptoms get better too. So it may be secondary to outlet obstruction. So urodynamics in the case of straightforward, genuine, plain old stress incontinence is very questionable. You really don't need to do it. If you're comfortable with the diagnosis, they have stress incontinence, you're done. But you have to be comfortable. On the other hand, if you have recurrent incontinence, really no one's going to question you if you're wanting to do urodynamics again. So recurrent stress incontinence, you want to look for overactivity. Other causes of incontinence could be poor compliance. We're going to do Valsalva leak point pressures on these patients to evaluate their outlet and most likely do a pressure flow study, make sure they're voiding okay, and make sure they don't have obstruction. If they did have a previous surgery, now you're going to use the urodynamics to help identify if they have an incontinence and if the previous sling, caused any problems. So that's it for the stress incontinence guidelines. Moving on to the AUA urodynamic guidelines. And again, I'm disclosure because I was on this panel, and again, I am not speaking as a member of this panel at this time, but I'm going to review the urodynamics as a separate person. Basically, the guidelines looked at urodynamics relative to all these diagnoses. So you can see here, let me see if my arrow comes up, all these urodynamic tests relative to the different diagnoses and how the urodynamics impacted diagnosis, prognosis, management, and outcomes. Today we're only going to be looking at the stress incontinence prolapse section. So these are the summary of the guidelines. These guidelines were done a little differently than the other guidelines. The other guidelines kind of reviewed the outcomes and just reported outcomes and basically had a few statements. These guidelines for the urodynamic guidelines were a little more, this is what you should do, this is what you shouldn't do, this is what you can do kind of thing. And that's an evolving process of how the guidelines were coming out. I imagine that the new guidelines all the new guidelines that have been coming out have been done more in this way. So for the patient with stress incontinence, it's considered expert opinion that if you're considering invasive therapy, you should check a PVR in these patients. And that's congruent with the stress incontinence guidelines. Again, these are the urodynamic guidelines, and they do fit the stress incontinence guidelines in that regard. If you're going to do urodynamics, you would want to do multi-channel urodynamics in patients with signs and symptoms of stress incontinence who are considering invasive therapy. Now, this is where we deviate a little bit from the stress incontinence guidelines. This is basically saying you can do it, and the other stress incontinence guidelines said you didn't need to do it. So some people say that they don't fit. Other people will say, yeah, they do fit fine. It means you don't have to, but this is giving you the ability to do it if you think you need to. And that's where, again, it comes into play. If you think you need to, because why? I'm not sure of the diagnosis, then you have every right and you should be doing it to make sure the diagnosis is correct. I would much rather you do a urodynamics test to make sure your diagnosis is correct before you do a stress incontinence surgery, rather than say, I think I'm right, but not be sure. So that bottom bullet there, it's not, everyone thinks urodynamics should improve outcomes, and it really should, and it didn't. That's what all the literature basically showed, that the urodynamic studies didn't improve outcomes. That's because the urodynamics were done, and these studies were done on women who were known to have stress incontinence. Well, if I knew they have stress incontinence, I don't need urodynamics on them. These are more for the questionable patients who may have stress incontinence, may have something else. Studies didn't look at those women. They looked at the one who were no shadow of it, beyond of a doubt. They had stress incontinence. So it's not about outcomes. It didn't improve the outcomes. If you already know they have stress incontinence, it's not going to improve your outcome. The treatments are the same. It's a sling. It's a birch, it's a mid-urethral sling, it's a bulking injection. And the Urodynamics did not steer you to one surgery or another because that's the surgeon-patient choice. However, if you're not sure if they have stress incontinence, and we're going to start talking about other treatment options, that's where Urodynamics will improve your outcomes. If you're going to do urodynamics and make the diagnosis of urodynamic stress incontinence, they should assess urethral function. And urethral function is meant to be Valsalva lead point pressures and urethral pressure profiles. And again, we'll go into that in a few minutes. Clinicians should perform repeat stress testing with urethral catheter. How many people have done urodynamics? I'm hoping everyone here has done them. If you haven't done them, you will see many times when you know you have a patient with stress incontinence and you do the Valsalva maneuver or the stress maneuver and they don't leak. They may not have stress incontinence, or more than likely they have a urethral catheter in their urethra, and that's causing a urethral spasm and is preventing leakage from showing. In that case, the guidelines panel decided it was best to remove the catheter, refill the bladder, then remove the catheter. Now the catheter artifact's not there anymore, and then redo the Valsalva maneuvers. Now they may leak. Now the problem is that the urethral catheter is not there anymore. How will you get a Valsalva lead point pressure because you don't have a F.A.C.S anymore? Well, the good news is you still have that abdominal catheter, or for the gynecologist in the crowd who may use a vaginal catheter, you have a vaginal catheter. They both measure intra-abdominal pressures, and at this point, the Valsalva pressure, the Valsalva lead point pressure, should be identical whether you're using a F.A.C.S or a P-abdominal catheter, so it doesn't really matter. And you remove that F.A.C.S catheter, you'll still have P-abdominal to work with. If you have a female with high-grade prolapse, POP is pelvic organ prolapse, clinicians should perform a stress test with the prolapse reduced as well as with descended. So we actually just do two separate runs. We do one run with the prolapse descended or down, and then we repeat the run with the prolapse reduced. Two separate runs. Some people think it's more work. I actually think we can get done faster. Plus, it's a little bit easier on the patient because you're not taking catheters out, moving out catheters, putting in prolapse, moving out prolapse every time. What happens if they don't leak the first time? Then you got to do it again. So to us, we just found this is a little bit more quicker and a little bit easier on the patient. But if what if what you're doing is working, you certainly do not need to change. So what do we want urodynamics to tell us before we go to stress incontinence surgery? What's the type of incontinence? If it's stress incontinence and we just didn't get it, we can't confirm it. Maybe it's a different kind of incontinence. How bad is it? Does that patient have a real low pressure urethra or ISD? We'll talk about that actually in the next slide. Can urodynamics guide us to the best procedure? That one is really hard because if you know they have stress incontinence, is there evidence that one procedure is better than another? And it's very iffy. The UITN trials done by the NIH basically said the TOT sling, the transobturator slings, and the transvaginal type slings, retropubic slings, were relatively similar in efficacy. Will urodynamics impact how we do the procedure? That's a different story. If you have a patient with maybe avoiding dysfunction, which you picked up on the urodynamic study, that may be one where you say, you know what, I'm going to do a looser sling, or some people believe that the transobturator sling has less risk of voiding problems than a retropubic sling. Well, if I see someone who has got voiding problems before surgery, that may be somebody I'm more likely to do a transobturator sling on. Are they at greater risk of failure? Patients with intrinsic sphincter deficiency do tend to do less well. So if I can identify those patients ahead of time, I might still do the treatment with the surgery, but they might have a different discussion. Most of us are, these days, the literature supports telling your patients you have a good, reasonable cure rate for putting in a mid-urethral sling of 85 to 90%. That's all comers. Maybe the patient with ISD is not going to be that high. So that's a reasonable discussion point. And then again, is there a greater risk of postoperative voiding dysfunction? If the urodynamic shows me that they're a strain voider, they have weak flow, that may be somebody who I'm more worried may have a voiding problem after surgery. Again, it may alter how I do the sling, or if nothing else, at least I'm going to tell her she's a greater risk. And I have on occasions been so worried the patient may have problems peeing that after surgery that I actually teach them how to do intermittent cath ahead of time. It does a couple things. First of all, it tells patients, I'm really worried you may have this problem, so that if they're aware of it. I mean, why would I make them learn how to do CI intermittent cath if it was just a mild worry? It's a real worry, and also it makes sure that they can do it, because if they can't do it and they're not willing to do it, they're not going to be a good candidate for it. And in my mind, lately I've been doing some legal defense work, and to me it's a good defense maneuver. If you did a surgery and someone goes into retention, and you took the time to say, I warned the patient, I was so worried that I taught them how to do intermittent cath, it's going to be pretty hard to say that you weren't worried or the patient didn't hear you correctly because you took those extra steps. So how do we evaluate the outlet? We really expect the outlet to be able to withstand higher and higher pressures, stress, without leaking. And why do we even care? Again, there are different types of incompetencies. There's the normal urethra or the genuine stress incontinence, where the urethra is working fine, but the urethra is very hypermobile, and they leak, but their sphincters are work fine. There's what's called intrinsic sphincter deficiency, also called the low pressure urethra or the lead pipe urethra, where the urethra tends to not move at all. They valsalva, and the anterior compartment doesn't move. In fact, the urethra will sometimes even just look wide open. A lot of times these urethras have had multiple surgeries and are scarred, especially scarred around surrounding the urethra, so that when they are compressed when you try and compress them, they don't compress very well, especially when they cough. These are the patients that may do worse with one type of sling, and you really want to identify them. Again, we talked about the possibility of these patients having worse prognoses. I'd still do the surgery, but I would talk to them differently. I might want to put in a tighter sling, or if they've had a previous midurethral sling and I see this ISD picture, that might be someone I want to talk to them about a fascial sling, because I can put those in a lot tighter and not worry about the erosion factor. I was always intrigued by that last bullet. There were, I don't know if there still are, but there were some insurance companies that used to require you to diagnose intrinsic sphincter deficiency, ISD, before you could do a bulking injection. Bulking injection like coaptite, the old collagen, Durasphere, macroplastique, all those things. Interestingly, the only way I know to make a diagnosis of ISD is with Urodynamics. Interestingly, the bulking injection, I think, reimburses $180, $200. Urodynamics cost the insurance company probably about 3 times that. So, I'm not saying it makes sense, but it just was kind of funny. You're going to evaluate the outlet with a Valsalva lead point pressure and or urethral pressure profile. The Valsalva lead point pressure, by definition, is an incremental increase in abdominal pressure until you see leakage occur. It's measured by the F.A.C.S catheter. Some numbers to remember. If you see leakage with the F.A.C.S of greater than 100, that means greater than 100, that means their VLPP is greater than 100. That implies that their urethra is normal. If they have leakage with less than 60 centimeters of water pressure, so they barely have any effort and leakage is pouring out, that's that low pressure urethra or the ISD. There is a gray zone between 60 to 100 where it's kind of iffy. A lot of us tend to now basically just use 100 as the cutoff. Kind of changed over time. A lot of times I'll use 100, or I'll also look for concomitant hypermobility. If they have hypermobility, even if they have a low pressure, chances are a retropubic sling or even a transoperator sling would work. But if they don't have hypermobility, then I'm a little bit more inclined to go with a retropubic type sling or even a fascial sling. This is a cartoon on how to do a Valsalva lead point pressure. On the x-axis is the bladder volume. On the y-axis, it says bladder pressure. This is meant to be F.A.C.S. Just an old slide. I don't like changing them too much unless I made it. So make sure you guys realize that's F.A.C.S. As you get to, usually the magic number is 200 cc's or half their bladder capacity. You have them bear down, and you bear down until the point where either leakage occurs or the patient can't do anymore. As soon as you see leakage, you annotate the event on the y-axis. That's going to be the P-vesical pressure. Can also be the P-abdominal pressure. They should be equivalent. That's the Valsalva lead point pressure. Why do we do Valsalvas? Coughs can actually generate higher pressures, but the problem is with a cough, the rise in pressure is so rapid and so quick that by the time you see the leak occurred, not only do they get up to the highest pressure, they're already on the pressure's already on the way down. So let's say, for example, this particular patient we're looking here as a Valsalva leak point pressure of 50. Well, they coughed, and by the time I saw the leak, even though the leak point pressure occurred here, I didn't physically see it until it was up there because it went up so fast. I can't tell you where on the curve it caused. It just went up real fast. On the other hand, Valsalva maneuver is a nice, slow, graded effort, and by the time you start to see leak occur, they haven't pushed too much farther beyond it. The issue here is that the fact that some patients will not be able to generate as high a pressure with the Valsalva, so we'll do Valsalva maneuvers first, see if they leak. If they leak, we're done. If they don't leak, then we'll have them follow up with a couple coughs. So let's say this patient Valsalva'd up to 80 and didn't leak, and then we do 3 coughs, boom, 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 and they get up to 120. If they leaked, I can't tell you exactly where. I know it's somewhere between 80 and 100 or 150, depending on how high they generated pressure. This is a real-life urodynamics with fluoro. You definitely do not need to use fluoro. It is more for teaching purposes right now. Basically, you can see the Valsalva effort here at 47 centimeters of water pressure. Leakage was running down. Again, easy to see on the picture, but you don't need a picture to actually do this maneuver. Excuse me. The problems with the Valsalva leak point pressure. Some patients can't generate a good Valsalva effort, especially I like to call them the little old ladies who plague my clinic. The little old ladies can't generate Valsalva pressure. They basically go, and that's the most they can do. There are a couple tricks you can do with that. One is my nurse calls it the blow technique, and you basically have them take their wrist and make up a good seal between their wrist and their mouth, so that their mouth, basically they're kissing their wrist. They have such a good seal between their lips and their wrist that no air can come out, and you basically have them blow on their wrist. When they start blowing on their wrist, as long as you don't hear any hissing noises, that also creates a Valsalva maneuver. How hard is enough? No one knows. The possibility of concomitant detrusor overactivity, what's called stress-induced overactivity, we'll talk about that in a couple slides. Standardized volumes. So it says no standardized volumes. Actually, when McGuire did this, and he's the one who did it in the 1980s, he actually did have a standardized volume. He said 200 cc's or half their capacity. Well, how are you going to know what their capacity is until you do the urodynamics? You might not, but you should, because your patient should hopefully be doing a bladder diary before they come, and you can look at the diary. And if the bladder diary shows volumes of 300, 400 cc's, you know you should be able to get at least 200 in there. And then you can do your Valsalva maneuver. On the other hand, if the typical volume is 100, 200 cc's, you know you're gonna have a hard time getting them up to 200. Then I would probably start doing the Valsalva maneuvers at 100 cc's or half their best capacity, whichever is better. Do you use raw P.V.E.S. or delta P.V.E.S.? That's McGuire again talked about using the raw P.V.E.S. Basically, the Valsalva maneuvers, before the Valsalva maneuver, their resting pressure may be in the 20s or 30s. Their outlet is seeing a pressure of 20 or 30. It's not leaking. Then you have them bear down. They go from 30 up to 60, 70. Let's say 70. They go from 30 to 70. So the true Valsalva leak point pressure is actually 70. Some people will say, no, it's 40, because the delta between 70 and 30 is 40. Again, their urethra wasn't leaking at a pressure of 30. Those first 30 centimeters of water pressure didn't magically go away. You added 40 more, so that is 70. That's how it was described. Do you measure P.V.E.S. or P-abdominal? McGuire used P.V.E.S. It doesn't really matter. They both, if your study is going well and your system is zeroed out properly, they should be identical. Clinical relevance is questionable because of the following. The original intent was to diagnose ISD because those patients were going to do worse if they had the older types of stress incontinence surgeries. They used to do these Ross bladder neck suspensions and birches and the old-fashioned fascial slings. If they had a birch, actually the best surgeries back then were birches and slings. And birches worked great except for ISD. And if you identified ISD on the study, those would be you'd more be inclined to offer a fascial sling. If they didn't have ISD, they could have either one. Nowadays, with the mid-urethral slings, it's not as important. But there is still enough evidence to suggest that patients with ISD don't do well regardless of what you offer them. So while it might not dictate which sling I use, it would still add ammunition for your discussion with the patient. Hey, you had ISD in your study. You may not do as well when you do a sling, so we need to keep those expectations into reality check. Also, some people do believe that it does impact the sling. Not everyone does, but if you do believe it, if you have ISD, they usually say the retropubic slings or the TVT type slings, they do better with that kind compared to the transoperator sling. So still maybe worthwhile to know it. Urethral pressure profile for gynecologists tend to be more comfortable with this. Urologists tend to be less comfortable with this, mainly from a factor of training. I've done both. I do both. They actually both are not so great and inaccurate. In fact, in the UITN trials, the urethral pressure profiles actually, if I recall, did a little bit better in terms of accuracy than the Valsalva lead point pressure. But we'll go over it in case whoever is doing them, just to be complete. Basically, the urethral pressure profile is the pressure needed to open a closed urethra. That was how it was originally defined by Brown back in late 60s. Catheter would be put in the bladder. You would measure the pressures in the bladder. You would then pull the catheter out. The pressure needed to open up the urethra would continue to rise, and when it would plateau, you reached your highest pressure. So you can see here the catheter is in the bladder. That eyelet is measuring pressures in the bladder. It's about 25. As the catheter is withdrawn into the bladder, you'll see a rise in pressure. It'll go up to the point of, this case, it's about 80. And then it comes back down again. The maximum urethral pressure in this case is 80. The maximum urethral closure pressure is the delta. In this case, it is a delta. The delta between the highest closure pressure and the baseline bladder pressure, it's 85 minus 25. Your closure pressure would be 60. These are all the fun facts and information you'll get with the urethral pressure profile. You'll get a profile, if you remember back from your, I guess, high school trigonometry, I'm guessing. A profile is basically a series of points pursuant to a specific equation. And what we're doing, if we go back, we're measuring a lot of little points of pressure points all on the urethra. And a profile is where you basically connect the dots and make a line or a curve that defines those points. So you're going to get a profile, and you're going to get a closure profile, which is the point where any of the urethral pressures are greater than the bladder pressures. The maximum urethral closure pressure, MUCP, is the one that we all hang our hat on. That typically is the one that's been used for diagnostic purposes and prognostic purposes. If your closure pressure is greater than 40, it's considered to be a normal functioning urethra that, quote, genuine stress incontinence is present, but the urethra itself is fine. If it's a pressure of less than 20, then we worry about what's that intrinsic sphincter deficiency, or the gynecologists like to call it the low pressure urethra. We call it ISD or lead pipe urethra. And of course, between 20 and 40, it's a gray zone. So we have lots of gray zones to give us lots of confusion. The other thing that the urethral pressure profile will give you, it'll also give you what's called the functional length, which is at any point where the urethral pressure is greater than the bladder pressure, and it tends to be about 3 centimeters or so. There is something called the pressure transmission ratio, which I honestly don't explain it very well, and it's very not something you'll be doing unless you're in academic urodynamic research labs and such. So you may see it in research papers, but it's not something that you're going to be doing in real practice, I don't think. This is what it would look like in real life if you were perfect. It's not usually like this because nothing is this smooth and easy to see. These are the points that you're going to be getting. Again, this is where the catheter is in the bladder. The catheter gets pulled into the urethra. You'll get a rise in pressure. You get the highest pressure. That's the maximum urethral pressure. The point where the pressure here, the delta between here and the baseline bladder pressures, is the closure pressures, and then you get length. This is one in real life. The catheter was in the bladder. The catheter was pulled into the urethra. You get a rise in pressure. Bladder pressures were 25. Pressure gets up to 85. The delta, 85 minus 25, is 60. In this case, there's 2 separate UPP pulls on one tracing. This guy in the middle here is the catheter going back in, and we didn't turn the machine off. Most people don't, but gives you a not so clean training. So UPPs were thought to be sensitive and specific for diagnosing stress incontinence. I actually do not think it diagnoses stress incontinence at all, because everybody has a urethral pressure profile, whether you have stress incontinence or not. But it may influence your choice of therapy. Again, if you have that ISD picture, you may not want to use a certain sling or a certain procedure or not, or you may want to talk to them about prognosis. Problems, again, no incontinence is associated with this test. Everyone has a UPP, whether you leak or not. And it's not been shown to be relevant as much nowadays with the slings we have and the procedures we have. So there you go. So that's it for the didactic portion. We're going to cases now. So like I said, we'll go into cases, and then doing all right with time. I was hoping to be a little bit quicker. Sorry, I'm long-winded. I'll stay on if we can, but we'll see how it goes with the cases and taking everybody off mute. We'll give you about a minute or so to say something, and then if you don't have it, we'll go on. I am sorry. All of a sudden, I have a cough that I cannot make go away. Give me 1 second. Okay. So our first patient is a 62-year-old female with recurrent urinary incontinence. She has lower urinary tract symptoms, including frequency, urgency. She's waking up 3 or 4 times a night. She has incontinence with stress and urge, but she's been on medications, did not get better for it. She is diabetic, so she's got mixed incontinence. It's not looking like she's that index patient yet. Here's her uroflow. She's got, actually going back one more thing, yeah. She's had a previous bladder suspension many, many years ago. Here's her uroflow. She's got a Qmax of 7. She's got a Q average of 4. She voided 82 cc's, and her PVR is 10. Now, the comments that you should be thinking about, she has an intermittent pattern. She has got a flow, it kind of stopped, it went back up again and stopped. She's got a very low flow rate, and she has a relatively inadequate voided volume. We like to see voided volumes of 150 to 200. These days, I'll take 100 sometimes even, but this is very concerning because her uroflow, or we know that the flow rate is determinant on bladder voided volume. It's very possible that if she could have held 150, she'd be able to have a higher flow rate. Here's her urodynamic study. This patient had a previous incontinence procedure in the past. Things you're going to look for: maybe she has recurrent stress incontinence, maybe she has overactivity, maybe she's obstructed. For those who can see the tracing, hopefully you can all see the tracing, there is no incontinence seen with these strain maneuvers. Each one of those strain maneuvers, I'm telling you, it's not there on the tracing anyway, but I will tell you if leakage occurs, and there was no leakage there. Basically, she filled to about 137 cc's and generated this unstable contraction. She had an urge at that point in time, and it resulted in effectively her leaking or voiding. She couldn't stop it. So we did another run. These are 2 runs pasted one on top of one another. Really about the same. See, the most she can ever get into her bladder is 160, and again she goes. And again, no stress incontinence is seen. So we're going to use what's called I call it the Wien classification. We call it the failure to store and failure to empty concepts. And if it's a problem of storage, is it the bladder's fault or the outlet's fault? If it's an emptying problem, is it the bladder's fault or the outlet's fault? In this case, is it a failure to store? The answer is yes. She's going too often. She's leaking. Is it a bladder problem or is it an outlet problem? Well, we didn't see stress incontinence. We saw overactivity, so it's a bladder problem. And she had failure to empty technically because her flow rate was low, but we didn't see any signs of obstruction. So the discussion points here are you really can assess the stress incontinence. In fact, most important reason I chose this case to start with is this lady may be having such bad OAB urge incontinence and going so frequently that she may be telling you, I leak when I cough. Well, she may leak when she coughs, but her outlet isn't a problem. She just happens to have an unstable contraction when she coughs. So she may be missing it. She may be confusing it, I should say. Basically, if she's having more frequent unstable contractions that she realizes, it's just coincidental that when she coughs and she happened to have an unstable contraction right afterwards that she leaked, but she equates that as stress incontinence. So we'll try this. Anybody want to raise their hands? Good.
Please click on your hand if you want to say something, and I will unmute you.
Okay.
I don't see anyone raising their hands.
Okay. So let's move on. 55-year-old female with incontinence. She leaks with hard coughs only. She doesn't leak with lifting or exercise. She has a little bit of urgency. She wakes up maybe 2 times a night. She doesn't have any prior medical history or surgical history. She's got no stress incontinence on exam. No prolapse is seen. Her UA is negative and her PVR is 15. Well, she doesn't sound like she's very complicated. She's got a history of stress incontinence with severe coughs. What's the missing thing here? Why is she an index patient? Well, the issue here is she's not, because she didn't leak with cough. She didn't leak on exam, I should say. And you really have to see the stress incontinence, even though she tells you, when I leak, I cough. Well, if you don't see it on exam, you can't assume it's there. You've got to check it. This is not an index patient. If she leaked on the exam, we can go straight to surgery or treatment. But because she didn't, we need to reassess, or at least assess her and find out why. A pad test, in this case Urodynamics, was helpful. This patient, to make a long story short, these are her Valsalva maneuvers, and this is a dirty study. And what I mean by a dirty study is there's a lot of artifact. Looks like the P abdominal has gone a little negative. Her baseline pressures were in the 15s, but we didn't have a baseline pressure here of 15, so it's subtracting out. That is a dirty study. Shame on me for letting this one even get through, but I like to use real studies. The question is, if you see this study, do you need to repeat it? And the answer is no. I don't think you need to, because the whole point here is the urodynamics should be answering a question. You should have a question, and the urodynamics should be answering it. And the question is, did she have stress incontinence, and is there anything else causing her to have these symptoms? So here she had Valsalva maneuvers. We didn't see leakage. No leaking occurring here. Here she had a Valsalva maneuver, no leak, and then all of a sudden she generates this contraction. Now, it wasn't associated with a leak, but she had an unstable contraction in a patient who I can't reproduce stress incontinence, but I can reproduce an unstable contraction with a Valsalva maneuver. This is a good example of that stress-induced overactivity. Again, stress occurred here, no leak occurred, nothing occurred, and then she had a contraction afterwards. We call that stress-induced overactivity. The unstable contraction prompted her to leak after the contraction occurred. She doesn't know I'm having a contraction. She just knows that when I cough, I leak. But what's really happening is I cough, that makes me then generate a bladder contraction, and then I leak. So that was the best slide of stress-induced overactivity I had. In reality, I can tell you a lot of times, even this patient, she had some urgency symptoms ahead of time anyway. And if you can predict it, I would offer this patient anticholinergics before I did anything to her outlet, especially since I didn't see stress incontinence. And if I had that inclination, even when I was talking to her, I might offer to her first. So let's move on. That case, and then we can ask questions again. 61-year-old female with complaints of stress incontinence. She denies any urge incontinence whatsoever. She's got some frequency. She wakes up 2 times a night. She's using 4 pads a day. On exam, she has hypermobility. She has stress incontinence seen. Her urinalysis is negative, and her PVR is 25 cc's. So what's the next step? Well, this is the index patient. She's healthy. She doesn't have any other complaints of voiding problems. Nocturia times 2 in a 61-year-old female is not unreasonable. She's got obvious stress incontinence on exam. She's emptying well. By the guidelines, by my opinion as well, I don't think you need to do anything. You could go straight to urodynamics, straight to treatment on her, and if she wanted pelvic floor exercises, that's great. If she wants to do a sling surgery, I think that would be fine. In my practice, this patient would not get urodynamics. However, she did. Now, I will preface this by saying this lady got got urodynamics because she was in a clinical trial, and it was a reasonably good study, so I wanted to put it on. But again, I want everyone to understand that the only reason this lady had urodynamics done is because she was part of a clinical trial. She did not need it. She could have gone straight to surgery. So now that being said, urodynamics illustrates a point. At 200 cc's, she didn't have any incontinence. No leak was seen. However, at 300 cc's, she didn't have any leak. But at 400 cc's, she did. And she had valsalva lead point pressures of 122, 125, 125. Just a housekeeping note: if leakage occurred, I'll either tell you, or hopefully there's an arrow pointing to VLPP there, or you'll see it in the flow tracing. In this case, she wasn't standing over the uroflow at the time of the valsalva maneuvers, but it's illustrated to you that she leaked because of the labels that are here. So she had VLPPs of 122, 125, 125. I don't see any overactivity. Then it came time for her to void. She produces a flow rate of 14, which is a little slow. Good news is that her regular uroflow was better. Her voiding pressures were in the teens. We filled her to 401. She emptied more than that, so she emptied all to completion. So she doesn't demonstrate any voiding problems. She doesn't demonstrate any overactivity problems. She basically is only demonstrating stress incontinence with a VLPP of 122. So that's stress incontinence with no ISD because her leak point pressures were greater than 100. For the gynecologist who like to use the urethral pressure profiles, here's her UPPs. There's 3 UPPs. Again, this is part of a research study, so they look a little different, but the curves are the same. 3 separate pulls. Closure pressures were 44, 42, and 46. So is this a failure to store? Failure to empty? Is it a bladder problem or an outlet problem? In this case, it was a failure to store, problem of the outlet. Do you think there's ISD or no ISD? Basically, with a valsalva lead point pressure in the 120s and a urethral closure pressure of 40s in the 40s, this is non-ISD. Honestly, she could have pretty much any incontinence treatment she would want. She can have a retropubic sling. She can have a transoperator sling. They both should work fine. If she wants to do pelvic floor exercises, more power to her, but she can pretty much anything she wants. Any questions on this one? Any hands going up?
None so far.
Okay, we'll get questions at the end, hopefully. Okay, our next case is a 46-year-old female with stress incontinence. She loses urine with physical activities, running, laughing, coughing. She's young, she's athletic, she's a dancer. She's not from San Antonio. She's not in my patient population because I don't get to see anybody who's young and thin. She uses 2 pads a day to prevent leakage with athletic activities. She has a little bit of urge incontinence, and she wakes up at least once a night. On exam, her past measure is relatively non-contributory. She also has stress incontinence on exam. She's got hypermobility. She's got no prolapse. So what would be our next step? Whatever PVR. Don't have a PVR. We said we'd like that for part of the guidelines, and we would like a UA. So I don't see that either. So I would want that at a minimum. I'm going to give you more. Here's her uroflow. I'll tell you her UA was negative. You can see she produces a flow rate of 19, and an average flow rate of 10. Has a relatively nice pattern with a PVR of 5. I actually am good enough with this. She's emptying well. Her PVR is low. People can argue she's got urge incontinence a little bit, but by history only it's mild, and you have obvious stress incontinence on exam. I don't think you'd be faulted if you did urodynamics because she gave you a history of urge incontinence. On the other hand, I don't think you'd be faulted if you went straight to treatment. She got urodynamics. I'm conservative sometimes. So you can see here She had a first sensation of 120, which I consider normal. Usually 100, 200 is normal. She had a capacity of only 250, but we filled her to 360. I'm sorry, we filled her to 250, but she ultimately put out 369. So that's better. And actually on the Uroflow, she put out 373, so that's also very good. She's holding almost 400 cc's. I don't see any overactivity. Interestingly, because she had some urge incontinence, but it's very mild. She has a valsalva lead point pressure of 108, so that's not ISD. And when it came time for her to void, she looks like she tried to strain a little bit to get it started. I said urodynamics may be needed for people who strain void or have voiding problems, but then she voided fine after that, and you can see her, that strain does show up on the flow point. You can see that right up there. But I wouldn't necessarily call this someone who's a difficult voiding problem, has voiding problems, because she's got a catheter in. Some women have to overcome that. They basically strain a little bit just to get it started. You can see she's not straining a lot at the rest of her flow pattern. You can see here her Uroflow was nice. It didn't have much straining here either. So I'm not convinced that she's a strainer at all. In fact, I don't think she is. And she emptied well. I mean, she had a nice contraction here, and she emptied all of it with really no straining after that initial strain. So here's her UPPs. You get, again, closure pressures of 49 and 49. So we've got a failure to store, bladder, or outlet. It's probably outlet. ISD or not, no, there's no ISD present, and she voids reasonably well with a question of a strain, which I'm not convinced is real. Interestingly, she also was part of a study, so I have urodynamics on her from 1 year later, and she has her flow pattern here, and you can see her Qmax 1 year after the sling. She had a TOT. Her flow, she's got a little bit of an intermittent pattern, but still relatively bell-shaped curve. She's emptying well. She's putting out 330. Interestingly, her closure pressure is increased. She's emptying well. She did well with that. So no ISD, stress incontinence, no voiding problems. Next is a 70-year-old female with recurrent stress incontinence. Now we're fitting more into the non-index patient or the more complicated patient. She's gotten progressively worse over the last few years. She's using at least 3 pads a day. She has some urge incontinence. Didn't think it was that bad to treat it. She's mainly bothered by the stress right now. But again, it's recurrent in nature. She had a hysterectomy and a Birch abdominal retropubic urethropexy years ago. Did well till about 3 years ago. She's had 5 vaginal deliveries. On exam, she's got stress incontinence that's seen, no prolapse. Now, this one, because she's recurrent, even though you see the incontinence, by history, she's got mainly stress, but there's several complicating factors here. One is this mild urge, which is mild, but it's still urge. And the other one is this is a redo or a recurrent procedure. So to me, that does justify urodynamics. And you can see here she's got a voiding pattern with a Qmax of 30 and a Q average of 17. She voided 360, 368, and really had a no PVR. So she's emptying well. She's got a lot of intermittent pattern here, though, and it does suggest the possibility of some straining. Why do I want the urodynamics? I said this could justify it, but why? What do I want this study to tell me? I want to know if the previous surgery impacted her incontinence or her voiding. I want to know if she's obstructed. I want to know, does she have ISD now or no ISD? I want to know if that urethra is fixed or not. So these things will help me. Here's her urodynamic study, pressure flow study. We'll tell you her sensation was normal. Her capacity was 430. Well, we filled her 382. She put out 434, so that's very good. Her contraction to void is a voluntary contraction, so there's no unstable contractions here at all. She valsalvated at about 200 mLs. I'm sorry, at 100 mLs. I can barely see. At 100 mLs, and she's got a valsalva lead point pressure of 85. Why would we have done 100 cc's when we got her up to 400? Well, probably on her diary, she had voided volumes in the 200, maybe 300 range, so we would have got nervous and we said, let's start doing them at 100 cc's just in case we can't get her up to 200. Well, we did get her up to 200, but she leaked with a valsalva lead point pressure of 85, and that was at that 100 cc mark. So that's stress incontinence with either the gray zone, or if you're going to use the newest terminology, it's really ISD. This is what we will often see, however, is you get a valsalva lead point pressure saying one thing, and you get a urethral closure pressure saying another. In this case, her closure pressure is 59 and 53. So is this a failure to store or a failure to empty? And is it an outlet problem, bladder problem, or outlet? Sorry, is it a failure to store, failure to empty? Is it a bladder problem, or is it an outlet problem? And then does she have ISD, and if yes, based on what? So it is a failure to store. It is an outlet problem. It's ISD if you look at the valsalva lead point pressure. It is not ISD if you look at the closure pressures. In my mind, if I'm not sure, I would go back to you looking at her pelvic exam to see if she's got hypermobility of the urethra. I'm tended to believe that she does not have ISD because the closure pressure was definitely greater than 40. And remember, her urethra, her VLPPs were in that gray zone. So I would tend to believe she does not. That one may be a good one to stop. Any questions on that one?
Please raise your hand if you have a question, and I'll unmute you. Shalene has a question. Go ahead, Shalene.
Hi. Shalene, are you there? Wheel? If you come back, flag us down, we'll bring you back online. Okay. Is there any chance she's typing her question? Do you see anything in the text?
No, I don't see anything typed.
Okay.
Her hand is raised, but maybe she's not there. I don't know.
Or maybe she's trying to talk and she muted herself too. Maybe self-muted.
She's there and she's typing a question.
Okay. And I closed. Let me see if I can get my box to show back up again. So I can't see her question. I've tried opening up a couple of things.
Okay, I have her question. She's asking, what if you do not do the UPPs, only Valsalva, would you diagnose her with ISD?
Not a bad question. That's that gray zone. So here we're back at that slide, and it's basically saying she's got 85 centimeters of water pressure. That's a very good question. I would probably, most of us do tend to now not use the gray zone anymore. I would probably label her as ISD because she's less than 100. The question is, how is it going to change your plan? And, will it change what type of surgery you offer her? If she has hypermobility, I'd be okay with anything. If she does not have a lot of hypermobility or has minimal hypermobility makes me tend to want to go to what's called a retropubic sling as opposed to that transobturator sling. So if she has minimal hypermobility on exam and a VLPP of 85, which suggests ISD, that to me is it should go retropubic and play it safe. So I hope I answered that question. All right. Next is a 54-year-old female who complains of a vaginal bulge and occasional incontinence, but she really has a hard time characterizing it. She also talks about difficulty voiding. She's got a weak stream. She strains, and when she does have to go, she'll get there, and it'll take a few seconds for it to start coming out. That hesitancy. She doesn't have any urgency or nocturia. She feels a vaginal bulge at rest. It's worse when she has a bowel movement. She's hypertensive. She's had a hysterectomy. Pelvic exam, I didn't say it, but I'll basically tell you she's got grade 3 prolapse. It's bulging out at, actually it's probably grade 3, grade 4. It's bulging out at rest, and it gets worse when she bears down. So this also is a good non-index patient. Several reasons. She's got incontinence that she can't characterize. She can't tell you is it pure stress, pure urge, just having a hard time with it. She has difficulty with urination. She's got difficult voiding. And not a surprise, probably that prolapse is causing it. And that prolapse is actually probably making it hard for her to characterize, because if she has stress incontinence, the prolapse could be kinking her urethra and then making it less obvious to her. So hopefully we'll be able to clarify what's going on and make her less complicated. So here's the urodynamics, and this is the first run with her prolapse hanging down. And let's see. We said we're worried about her having incontinence, and we're worried about her voiding issues. So this is the bladder. That's her prolapse. Everything should be staying up here. But you can see she's got a protrusion coming down, and this is all bladder blowing down. So she has a cystocele. She's got more than that on exam, but she's got a cystocele causing prolapse. When this is down, she does not have any stress incontinence. We had her Valsalva several times, got a cough several times. No leak. She held a good amount. She held up to 360. But what was interesting was when she voided, she had a Qmax of only 8, which is relatively low. And it produced, she was able to get most of her urine out. Not all. Actually, I take it back. She was only get about half of her urine out. She voided 183. We put in 360, so she only got half of it out. So she got a high PVR. And on top of that, the voiding pressure necessary to produce a flow of 8 was about, that's 50, so that's coming in about 45 or so. So Qmax of 8, pressure of 45, that's obstructed. And that's why she's having a hard time with her voiding. The prolapse is most likely kinking her. Now we have her do the second run. This swirly motion is how we reduce our prolapse. We use some people do it differently. We use gauze and pack up the vagina that way. Some people will use a pessary. Some people will use ring forceps and get on their knees and push it up and manually hold it up. My knees are too old. They don't do very well when I'm on there for a long time. Also, this is our best way. We tend to think this is the least likely way to obstruct her urethra. I give a fair amount of liberty to my urodynamic nurses. They're very good at what they do, and they know they've learned over time, because we have a prolapse kit. We could do easily prolapse fitting them, but they really have come to the conclusion that we're less likely to obstruct the urethra and cause artifact when we use the gauze. That's just how we do it. If what you're doing is working, please do not assume it's the only way, and you should do what you like because it works. But in this run, her prolapse is reduced. Now, all of a sudden, she did have stress incontinence, and she has a Valsalva lead point pressure of about 80. Great, that gray zone again. And let's look at her voiding now. Now she's got a much better flow rate. She's doubled her flow rate. She went from 8 to 15. Her pressures, they actually cut in half. They were in the 40s. Now they're in the 20s. So we made her flow better. We made her pressure lower, unobstructed her. And she's emptying better. We filled her, and she produced about 420. So she's getting much more urine out now. So to me, this is a great study, great example of the non-index patient. She had voiding problems. She has occasional incontinence that she couldn't characterize, and she had a bulge. Is it a failure to store? Is it a failure to empty? Yes, it's a failure to store due to the outlet. She had a Valsalva lead point pressure of 75. When her prolapse was reduced. Is it a failure to empty? Yes. She has outlet obstruction due to the prolapse, which got better on the urodynamics when you reduced the prolapse. So that gives me a lot of confidence that fixing her prolapse will do a couple things. It gives me a lot of confidence that fixing her prolapse is going to make her pee better. It also gives me a lot of confidence that if I fix her prolapse and don't do anything else, she may have incontinence afterwards. So I will have that discussion with her. And let her decide if she wants to do a concomitant sling or not. There is a question, because if she does have voiding problems now, and then she has persistent voiding problems later, and I put a sling in, then the question is maybe her voiding problem is due to the sling, or maybe the voiding problems are still the same problems that we had that we didn't correct. So there is no right answer there. It's basically a discussion between you and patient. again, I'm more comfortable with her because we made things better. If you're not sure, maybe a good patient to put a temporary pessary in. That will mimic what the surgery will do. If her prolapse is gone with the temporary pessary and she comes back and says, hey, I'm peeing great, but I am leaking, well, that tells me that a concomitant sling is probably in her better interest. But if she comes back and says, I'm still peeing problem and not coming out as easy, maybe that's a staged procedure. That's maybe someone who gets a prolapse repair first and then come back, and if she's leaking still but voiding okay, then you can do a sling later on. It sounds horrible. Oh, I don't want to do 2 surgeries if I have to, but I'd much rather put in a staged sling than go back and do a staged sling release if I put the sling in and she had problems peeing. Another female, she has stress incontinence, a little bit of urgency, also has voiding problems, feels like she has to strain void. She has recurrent UTIs, she's diabetic. On exam, she's got stress incontinence, she's got a cystocele, she's got a post-void residual of 200 cc's. So what do I want to know, and what's the next step? Well, I want to know if that 200 cc's, it's probably causing her UTIs. I want to know why. Is she getting 200 cc's because she's diabetic and she has a diabetic cystopathy? Bladder's not contracting well? Or maybe her prolapse is bad enough that it's obstructing her, and she's obstructed just like the last lady. That's what's causing her to get the high residuals. So urodynamic, this is again a non-index patient. The urodynamic should be able to tell us what's going on. First part of the study, we had her do Valsalva maneuvers, and her Valsalva lead point pressure was 75 centimeters of water pressure at 200 cc's. Again, it's kind of in the gray zone. I'm going to say it's ISD because it's less than 100. But then it's time for her to void. And she didn't do very well. We filled her. She had a capacity of 850. Ouch, that's a lot. She put out 563. You can see that she voided a little bit here, and then a little bit there, and then a lot more there. But she still didn't get it all out. So why is she not emptying? And man, that's one massive bladder contraction, isn't it? So she's got a Qmax of 20 and a pressure that's coming off the radar screen there of 134. Well, that would sound like she's obstructed, wouldn't it? But this study doesn't look right, does it? First of all, what happened to her P abdominal? P abdominal went flat. Nothing ever goes flat in urodynamics unless you disconnected it or unless there's some sort of artifact. Also, looking at it, this is not a bladder contraction. I mean, I guess it could be, but it doesn't look right. I don't see a steady rise, and that is one hell of an obstruction if it's present. The other thing, most important, is if you see something in PDET, if you think there's a contraction present, then it should also have been present in P.V.E.S. And I don't see it in P.V.E.S. In fact, I see a lot of these things in P.V.E.S. which look like straining to me. Well, if they're straining, I should see them in P abdominal. But I don't see them in P abdominal. I don't see anything in P abdominal. The reason I don't see anything in P abdominal is because she was straining, and she strained so hard, she pushed out the abdominal catheter. In our case, it's a rectal catheter, but if rectal catheter, vaginal catheter, doesn't matter. She strained so hard that she pushed it out. Now, what did I want this study to tell me? I wanted it to tell me, why does she have a high residual? Is she obstructed, or does she have a diabetic cystopathy? Well, chances are, based on this test, she's diabetic cystopathy. There's no contraction present here at all. I mean, you could argue with me, oh, I got to repeat the test because this happened, all this junk happened. Well, yeah, it did, but I don't like to repeat tests if I don't have to. And I need to know, does she have a bladder contraction? And if she did, it would have shown up in here. You could argue, well, if you had seen a rise in pressure here, you wouldn't know if it's a contraction or if it's straining. Well, I don't see a contraction here. I see lots of rapid rises. Rapid rises are straining. So if you want to be purist and you're not comfortable with that jump, repeat the study. But prior to the catheter coming out over here, there was no contraction. Basically, her means of voiding is straining. She strained the catheter out. So is this a failure to store or empty? Is it a bladder problem or outlet problem? It's a failure to store and empty. It's both. The failure to store is due to an outlet problem. She has that lead point pressure of 75. And it's a failure to empty due to the bladder. She's hypotonic or atonic. In this case, she's atonic and a strain voider. And how is this going to impact my treatment? This one is a great example. It's definitely going to impact. I'm going to have a long discussion with her, and I'm going to tell her, well, if you want me to make your stress incontinence go away, I can do that, but the same thing that makes her stress incontinence going to go away is going to probably put her at a greater risk of post-op retention. In fact, she probably should be treated for her PVRs of 200 anyway because she's getting recurrent UTIs. And if I did a sling on her, she's going to get worse. So either I would teach her how to do intermittent cath, or I would probably not want to touch her, at least with surgery, because this is someone who's at a high risk of going into retention. She's already a strain voider, and as soon as you strengthen that pelvic floor, fix her prolapse if it's there, put a sling in there, and she won't be able to void at all, in my opinion. Questions on that one?
Kimberly Wright has a question. Go ahead, Kimberly.
Hi, can you hear me?
I can.
Okay, very good. I have to preface my question with saying that I am a generalist OBGYN with a nurse and a physician assistant who do the urodynamics, and I actually have a urogynecologist who comes in and reads them and then sees the patient. So my basic knowledge is very minimal to none.
So, don't shortchange yourself.
Well, what I wanted to ask is, do you have some kind of arrow or pointer or some? Because I am so lost that I don't even know what questions to ask. Because you're like, if you look over here, you see that this contraction is happening here, and over there, you see right here is happening this and that. So I'm like, over where? I'm looking at, and then you need to say these numbers, and you say,
I'm sorry,
where
my arrow.
is 100? I don't see, I can't. Oh, there's your arrow.
That's my arrow. Yeah, I apologize. My arrow was,
because I've been lost.
All right, my apologies. My arrow was not coming on. My Bluetooth wasn't working. Okay, so let's go back. So here's her study. Here's the beginning of this study. She's straining here.
Mm-hmm.
Okay, and she leaked with that. You didn't see it here, but you see it on the X-ray. And she had a VLPP of 75. Then she started to void. And this is where I'm looking for a bladder contraction. So here we got her flow. And we can see she's got a flow here that starts and then stops, starts and stops, starts and stops. Is there a contraction associated with this flow? There's this massive red thing over here.
Mm-hmm.
And that could be a contraction, but if it is, it's a high-pressure contraction. And if I see it in PDAT, I should see it in F.A.C.S, but I don't. This definitely does not look like this. In fact, I don't see any contractions in F.A.C.S. What I see are a lot of rapid rises, ups and downs, ups and downs. And if that's the case, these look like strains to me. Well, if they were strains, they should show up in P-abdominal. They should show up in both. But they're not. And why are they not showing up in P-abdominal? Well, P-abdominal is not working, and it stopped working right there. It went flatline. And that something happened. In this case, she was pushing so hard, she pushed the catheter out. Once it goes out, it reads atmospheric pressure and goes to the flatline. Any straining that occurred, we didn't see in P-abdominal because that catheter wasn't working. But I need to know. And you see, that's what happened with my arrow. I had it, and it goes away. If she'd had a contraction here and we were missing, we would have seen something that looked like a bell-shaped curve in here, or at least something that looked like a contraction. And I know I see these rapid rises. So I don't think she's having a contraction. My mind, I'm good enough to say I'm not seeing a contraction at all. I just see lots of strains. The purist would say you can't say that without the P-abdominal, and that's fine. I can't argue with it. If you need to do another study to make yourself comfortable, then you do. But if you've done enough of these, you'll see that this is what strains look like. How do I know? It's from just doing a lot of them. But look over here. Same thing. This patient, we know she was straining here because we told her to strain. And this looks like those. On the other hand, let's go back to another study. Here we have someone with a contraction. That looks like a contraction. This is a far cry from one of these.
Mm-hmm.
These are strain maneuvers, Valsalvas. That's a contraction. Catheter is still working here. The P-abdominal catheter is working. So we see a little blip here. That's not much. If this is a contraction, I should see it in P-det. I shouldn't see it in P-abdominal, which I don't. But I should see nearly an identical thing in P-VES. So this does look a lot like this part right here.
Mm-hmm.
So this catheter in the P-VES catheter picked up this contraction. The P-abdominal catheter tells us there was nothing going on in the abdominal cavity with it. That's a real contraction. And she voided with that. She had a Qmax of 8 with a pressure of 45-ish, and that's obstruction. In this case, we did another run. We reduced her prolapse. Now she's got a Qmax of 15. Pressures are only in the 20s. No obstruction. I apologize for my arrow not working.
No, thank you. That was much more helpful. Thank you so much.
You're welcome. Okay. Good. Luckily, I had. Oopsie. Sorry about that. Went all the way to the end. Let's go to the very end. Actually, let's do this. So we got to the end of that last case. Okay. So, conclusion. For the index, straightforward, I don't have any question. She has stress incontinence. There's no question in my mind. You don't need to do urodynamics. You really don't. It's straightforward. You should be comfortable with moving on with treatment. However, if you're not comfortable, that's where urodynamics comes into play. The basic question you should be saying is, what is urodynamics going to do for me on this patient? If it's just going to make you feel better, I know she's got stress incontinence, but I was taught a long time ago that I use urodynamics to confirm it. That day and age it has been shown it's not worth it. There's no advantage to it. But if you're not sure of the diagnosis, if you're really not wanting to confirm the diagnosis, but you're just not sure, that's where urodynamics does help. For the non-index patient, especially the recurrent SUI patient, the mixed incontinence patient, those voiding dysfunction, elevated post-void residual, significant prolapse, neurogenic bladders, that's where urodynamics will help you. Bottom line is, when you bring that patient into the urodynamics room, you should have a question that the urodynamics is supposed to answer, and try and get that answer before you leave the urodynamics room. If the urodynamics didn't answer the question, then it didn't help you. Try again, or redo the study, or see why it's not answering. So that's the end, and I will certainly answer questions, especially since I've got an arrow that now has a new battery in it. Let me know if there's any questions.
Dr. Kraus, there is a question. The question is, what is the difference between IH2O and VH2O? At the recent Laborie workshop, Dr. Gray talked about a cough UPP test for SUI. What are your thoughts on this? Oh, those are two different questions. I'm sorry.
Yeah. No, that's fine. So the IH2O is the infusion rate that the patient study was getting done at, and the VH2O is the volume that was infused. So in this run, we usually do our runs at mid-speed or 50 mils per minute. In this run, this was a second run, so I was kind of in a rush. You can see when I get rushed, I turn the rate up, and this one was at 79.7 or 80 cc's. So at 80 cc's, and at the end, at this point in time, the amount of urine that was in her bladder was 360. That was her filled volume. Her voided volume over here is 188, 183. So IH2O is infusion rate. VH2O is the volume in the bladder at the time of the study. And then the other question was, what was it again? Cough lead point pressure versus what?
It was about a cough UPP test for stress urge incontinence. What are your thoughts on that?
Ooh, a cough UPP. Cough UPPs are not. Now you are talking about that pressure transmission ratio. When you're doing a cough, you're measuring how much of the cough pressure transmit into the urethra. I'll be honest, very few people do that. It is not the one that is. When you look at a study, when you look at a paper that talks about, this sling did better with this kind of closure pressure, they are not talking about cough UPPs. So I don't do them, and I don't think literature. Not that they're bad. I'm sure, I know Dr. Graves, he's a smart guy, so he knows what he's talking about. But the problem is that he's giving you information that you then can't go back into a paper and say, well, according to this research paper, with this cough UPP, the answer is I should do this. That doesn't exist. Basically, the only thing you'll find in literature is when my maximum urethral closure pressure, my MUCP, was this number, I should do this surgery or this treatment. So I hope that answered your question. Any other questions?
Not at this time. Does anyone else have a question? It appears not.
Okay. Well, thanks again, everybody. We're doing another one, I guess, next month, but we will see, because we'll see on topics and such, and I know Laborie will talk to you guys. Hopefully this helped you going over cases. Hopefully it reinforced some stuff. Kim has a handout now that she'll give to you guys. If those were you, if you were on the previous, she'll talk to you about that one as well. And thanks for staying on.
Thanks, everyone. Have a great night.